so now we're looking at, well, what could be the other drivers of pelvic girdle pain? And there's a lot of literature that's starting to come out that's going to be published, but Sinead Dufour out of McMaster's and her group, that group up there, is really looking at a lot of different, what may be more systematic drivers for pelvic girdle pain or pain in pregnancy. And one of the things that they're beginning to understand is that it's probably much more due to people living in a cortisol-rich environment than for other reasons. They're doing cortisol salivary tests on these people that are having pelvic girdle pain and on the ones who are not. And guess what? It's showing high. So it makes you think about that, because our patients who have pain, you know, they've got a response to that. They've got a stress response to that. And over time, that stress response turns into producing more and more cortisol to keep that response going. So now we kind of get into the whole idea is like, well, if we can figure this out and it's working like pain like we understand, then what we need to do is A, get people not to be afraid of it, and B, teach them how to move where that they can begin to change those patterns and change that overprotective response system that's coming up. So all of the movement stuff is great, but we may need to teach it in a way that isn't driving the fear avoidance belief or the pain catastrophization or the kinesiophobic kinds of responses that we're seeing in a lot of our clients. I also think it's fun to challenge your confirmational biases. You know, just go in there and say, what if it isn't that? What if it's something completely different? What would it be? You know, and this brings up another question I know you were going to ask a little bit about, is relaxin the devil? You know, and so a lot of this, you know, the research is very controversial on relaxin. And one of the big drivers about why I just can't buy into the relaxin theory is that there is not receptors in the pelvic girdle joints for relaxin. So relaxin comes on at, it also you have to look at when it actually comes on, when it's more prevalent, and it's usually a couple of weeks before delivery is when it peaks. And it actually tapers off pretty darn fast in the postpartum period. It doesn't hang around for 4 to 6 or 8 months like everybody thought it did. It's got a pretty quick uptake and decrease, and so there's reasons for that. It obviously changes tissues elsewhere that, you know, can be very important for the delivery system and things like that. But I think people are starting, you know, in the literature, you'll start to see the shift, or if you've watched it for the last 10 years, the shift has been, what about estrogen? Because there's a lot of affinity for estrogen in the pelvic girdle joints. And estrogen is prevalent during pregnancy, more so than other times. And if you have pain before, then you may have a sensitivity to that estrogen receptor. And then when your estrogen rises again, that may be why we get more pain as we go along, or the prevalence of estrogen over many pregnancies could be one of the drivers. So there's, you know, there's so much out there that it's just exciting to not have to pin it on this one thing, but start thinking about, wow, it could be, you know, a lot of these other things. And why does this person get it and this person doesn't? Built the same way, and this person may have, you know, on the mobility scale, maybe both of them are towards Gumby. They're not fire hydrants. They're more like Gumby. They're not on the edge, on the other end of it. But this person ends up with pain and this person doesn't. You know, and I've seen plenty of people who move very, very, even joints that move beyond what we consider like the normal range, you know, on the Brighton or Brighton scale, and they don't ever have a problem. Blame it on that. And that's the thing is that, you know, it may be something we look like we can hang our hats on because that's all we're seeing, but we got to remember that there's a whole population out there that doesn't have this problem, and we're not looking at them in comparison to these. We're just looking at these people because that's what's walking in our door in the clinic. So if you look to the guideline, it's not a protocol, but to the guideline, there are suggested tested measures in there for this population, and the evidence with the sensitivity and specificity are there, which can be very helpful. And those were all very well described by Dr. Albert in 2000, I believe. And then Chad Cook came along with his group at Duke and actually validated that, plus added another criterion, and actually found that some single tests were just as good as clusters. So, but without getting too far into it, with all the, into the weeds with all of that stuff, the first thing that I do is I sit down and listen to their story. I want to hear the story. I want to hear when this started. I want to hear what they believe about it. I want to hear what they're afraid of. and I want to hear what their expectations are. Because if I don't get to those things, I'm not going to get very far with them. But the belief is what I really need to get into first with them. It's like, what do you believe is really, really wrong? And what are you worried about? Because most of the time, if you can get them to really sit down and tell you what they're really worried about, it's not what you think it is. It's not that I just want to get out of pain and be okay. It's usually something deeper and darker that I had somebody, the last person that I saw who had a very sensitive pubic bone on one side, and really believed that her pubic bone was going in and out, and that as she moved, she would pop it back in or pop it back out. And a lovely person. And, what was bothering her the most and the things that were, so she would tell me about in bed, out of bed, up and down on the floor. She had a toddler and she was pregnant again. And finally we just, so I knew that she kind of bought into this belief that, that she was pretty fragile and that this had to pop into place for her to feel better. Until we could kind of start confronting some of those beliefs that didn't always happen. She didn't always feel a pop, she didn't always, there were things that, occurred. But the other thing is that when I finally asked her, I'd gotten enough, trust with her. And I said, what are you really worried about? Like really in your heart of hearts, what are you really super worried about? And she said, another person told me I needed to get a handle on this because they had a problem and they fell on the stairs and dropped their baby. Okay, that's a game changer. The way I'm going to work with this person is going to be way different than just treating, her pain and telling her that this and that. This person has something that really needs to be handled. She needs to know how strong she is. She needs to know that she's good on stairs. She needs to know that she can get up and down, and that pain doesn't always equal harm with her, that she has the ability to change this and, and go through. And so the other thing that I do before they even come in the door is and I take the titles of the functional outcome measures off of there. So all of you who are using, like the different forms, like my favorite one is urinary distress inventory. Why are we handing somebody a form that says that? I just we're already biasing them right off the bat. So I use forms but I take that title off. I've retyped them and set them, and they have a different look to them. They're on a different color of paper. They look like a questionnaire and not like I'm trying to get something out of them. But I use fear avoidance. I use the pain catastrophization scale, and I use the Tampa kinesiophobia scale. And I'll use the pelvic girdle questionnaire, pelvic girdle pain questionnaire. And I do that for a reason, because if they are in the catastrophization, like if they score high on those, I can actually use that questionnaire to guide our discussion and talk like, what do you think about this? Why did you, tell me about this? You scored this really high, or you scored this really low, like your ability to take care of yourself. I want to hear more about that. That's going to drive my treatment way more than if I'm going to put my hands on and move them back and forth or any of the other things. Yeah. So that's what I do first. After I get all of that, now we're getting into the meat of what everybody wants. Like I do a lot of functional movements first. I don't really ever put my hands on people's pelvises so much. You can, there's nothing wrong with it. But I do a lot, I take a look at things. I just take a look at, they stand up and I'll just ask them questions like, are you hurting right now? Tell me if anything that you do, I want to know if it makes it worse, better, or the same. And just right now, what's happening? And if we can actually, where are you standing on your feet? 9 times out of 10, if they're pregnant, they're back on their heels. Not always, but they are. What happens? And you're feeling that your symptoms right now, maybe yes, maybe no. And if they are, we'll just say, can you shift on your feet to where you're not standing on your heels anymore? Just enough, like towards the balls of your feet. Does that change anything? Let's hang here for a minute and see what happens. And we start just changing strategies like that right away, because they're now standing upright, and load transfer is a huge piece for the pelvic girdle. Then I'll move into bend overs, side bend, try to centralize their pain if it's going down the back of their leg or their side of their leg, because I want to know if it's really more in the back, or if the back is more of a driver than something else, and I can centralize it. Then I know I need to probably spend a little bit more time helping them with their back a bit, and or movements that are gonna decrease that pain going down. And, we'll stand on one leg. We'll stand on the other leg. We'll shift back and forth a few times, because load transfer is so important. And if they can't handle load transfer like that, I'm not going to do a step up. We got to get that a little bit better and get them feeling good with that and give them better strategies for the stairs. So this is where I'm still a PT like you'd think I should be. I look for Trendelenburgs. I look for weight shift. I look for overshifting. I look to see how they're handling that load transfer and if that load transfer is actually driving their symptoms up. Or they may stand on, they have right-sided, pelvic girdle pain, and they stand on the right side and it feels pretty good. And it's like, okay, well, what would happen if you shifted back out, because they may shift way over or something, and they've learned to do that because it doesn't hurt as bad. It's like, what if we just kind of like put your hands on the wall or on this table here, stay still and just lift your left leg up? What happens? Oh, that really, really hurts. That tells me something, that if they can't shift, that increases their pain. And so, or sometimes it's they stand on the other leg and lift that leg up, and the open chain movement is one that they don't like. So that can kind of give me a lot of ideas about where I need to go with them and what I need to do. But I look at those load transfer things right away. The pelvic girdle pain questionnaire and the work by Gutke has discussed the active straight leg raise test. I think probably pretty much everybody's familiar with that. They lay on their back, they raise one leg up 12 inches off the table. That's merely a test of load transfer. It really is. It's just you're laying on your back for it. And then you go in and you put a belt on them and you say, does that feel better? Yeah. Does it feel better? So we have to not say stabilized, but what the belt does something important, just like tape. Tape doesn't stabilize the patella or the scapula, right? We already know that, but tape gives sensory input. And sensory input is going to go a lot further to changing the coordination pattern of the output of the motor system than anything else, because it's the fastest way in and out through the cerebellum. So a belt suits a purpose. It helps get muscles, particularly the muscles around the pelvis, to get a little sensory input and maybe perhaps stop being so inhibited and be able to kind of do that. And then you take the belt and you stand them back up. Their pain doesn't get any better. Sway forward, do something. Let's see if we can make this belt work. What does load transfer look like now that you have the belt on in the upright position? Because I'm going to tell you right now, people aren't going to wear the belt to bed, and they're not going to wear it if they have to sit and stand a lot. Yeah. Where they're going to put the belt on is when they need to go for a walk. That's when they're going to do it. And I just know this from experience, because that thing is a pain in the neck to take on and take off, and you cannot sit in it. So I like a lot more of the ones that are like more movable and a little bit more elastic, that allows them to sit and stand in them, just because I have a better shot of them wearing them a little bit longer and it feels more comfortable to them. So, but sometimes they need that good old fashioned Sorolla belt or their husband's belt or whatever you have available, something that can be just kind of a little bit on the rigid side, because it just gives them the input that they need. And sometimes that input just makes them feel like I'm just pulled together better, or I have better control, or whatever it is. I've asked my patients numerous times. I said, it just feels like I have a boundary or something. They don't really even know how to describe it. But I don't want them to feel like I can't be stable without this belt. Mm-hmm. It's like it's just a thing to calm things down right now when we get you going, right? Because people just aren't going to wear them forever, and they shouldn't be wearing them forever. Is my hope.